In this lecture, we will be covering pulmonary embolism, hemorrhage and infarction, pulmonary hypertension, diffuse alveolar hemorrhage syndromes. Blood clots that occlude the large pulmonary arteries are almost always embolic in origin. As it's well known, more than 95% of all pulmonary emboli arise from thrombi within the large deep veins of the legs, most often those that have propagated to involve the popliteal vein and the large veins above it. Risk factors for venous thrombosis includes the following: prolonged bed rest, especially with immobilization of the legs; surgery, particularly orthopedic surgery on the knee or hip; severe trauma, as in burns or multiple fractures; congestive heart failure. In women, the period around parturition or the use of oral contraceptive pills with high estrogen content; disseminated cancer; primary disorders of hypercoagulability like factor V Leiden. Two important consequences of pulmonary arterial occlusion. The first is an increase in the pulmonary arterial pressure and vasospasm. The increased pulmonary arterial pressure happens due to the blockage of a flow. Vasospasm is caused by the release of mediators such as thromboxane A2 and serotonin. So if a major vessel is occluded, an abrupt increase in the pulmonary artery pressure will follow, and the heart will be pumping against higher resistance, resulting in decreased cardiac output and right-sided heart failure, which is called acute cor pulmonale. In some cases, this may result in sudden death. If smaller vessels are occluded, the result is less catastrophic and may be clinically silent. Furthermore, pulmonary arterial occlusion causes ischemia or decreased blood flow to the downstream pulmonary parenchyma. And as you know, the lungs are oxygenated not only by the pulmonary arteries but also by bronchial arteries and directly from air in the alveoli. So ischemic necrosis is uncommon, affecting as few as 10% of patients with a thromboemboli. The pathophysiologic consequences of pulmonary thromboembolism depend largely on two factors. First, the size of the embolus, because this factor determines the size of the occluded pulmonary artery. Second, the cardiopulmonary status of the patient, which means the general state of the circulation. So large embolus may embed in the main pulmonary artery or its major branches or even at the bifurcation as a saddle embolus, while smaller ones become impacted in medium-sized and small-sized pulmonary arteries. This figure shows the gross appearance of a large saddle embolus from the femoral vein lying astride the main left and right pulmonary arteries. The morphologic change of the embolus depends also on its size and general circulatory status, as some large emboli may cause sudden death, so no morphologic alternations can be appreciated. Alveolar hemorrhage may be seen with a smaller emboli as a result of ischemic damage to the endothelial cells. With compromised cardiovascular status, as in congestive heart failure, infarction results. So the more peripheral the embolic occlusion, the higher the risk for infarction. And that's explain the fact that 3/4 of all infarcts affect the lower lobes, and more than 1/2 are multiple. Infarcts are wedge-shaped, with their base at the pleural surface and the apex pointing toward the hilus of the lung. Pulmonary infarcts typically are hemorrhagic and appear as raised red-blue areas of coagulative necrosis in the early stages. The adjacent pleural surface often is covered by a fibrinous exudate. The occluded vessel is usually located near the apex of the infarcted area. Red cells begin to lyse within 48 hours, so the infarct gradually becomes red-brown as hemosiderin is produced. Then fibrous replacement begins at the margins first as a gray-white peripheral zone and eventually converts the infarct into a scar. This figure shows the gross appearance of a small, roughly wedge-shaped hemorrhagic pulmonary infarct of recent occurrence. This figure shows a thromboembolus in the peripheral pulmonary arterial branch. If there are numerous small peripheral thromboemboli, then the vascular bed is diminished and the pulmonary hypertension may occur. Pulmonary thromboembolisms are mostly clinically silent because they are small, so the bronchial circulation sustains the viability of the affected lung parenchyma, and the embolic mass is rapidly removed by the fibrinolytic activity. In 5% of cases, death, acute right-sided heart failure, or cardiovascular collapse occurs suddenly, as in massive pulmonary embolism. This typically happens when more than 60% of the total pulmonary vasculature is obstructed, either by a large embolus or multiple simultaneous small emboli. In 10 to 15% of cases, pulmonary embolism is associated with obstruction of small to medium-sized pulmonary branches. As a result, pulmonary infarction will follow, especially if some element of circulatory insufficiency is present. Those patients usually present with dyspnea. In a small but significant subset of patients accounting for less than 3% of cases, recurrent showers of emboli happens leading to pulmonary hypertension, chronic right-sided heart failure, and in time pulmonary vascular sclerosis, with progressive worsening of dyspnea. Management includes prophylactic therapy, which may include anticoagulation, early ambulation for post-operative patients, application of elastic stocking, intermittent pneumatic calf compression, and isometric leg exercises for bedridden patients. Those who develop pulmonary embolism are given anticoagulation therapy. Candidates for thrombolytic therapy include patients with massive pulmonary embolism who are hemodynamically unstable, as in shock patients. Non-thrombotic pulmonary emboli come in several uncommon but potentially lethal forms, including air, fat, and amniotic fluid embolism. Bone marrow embolism happens due to the presence of hematobiotic and fat elements within the pulmonary artery. This can occur after massive trauma and in patients with bone infarction secondary to sickle cell anemia. IV drug abuse is associated with foreign body embolism in the pulmonary microvasculature.